Welcome back to another NRG Oncology podcast episode. Today, Stephen and I are reconnecting with someone we both know very well. I've personally known Dr. Jeffrey Bradley since I was a medical student and a resident in radiation oncology at Washington University in St. Louis, where he was the lung radiation oncology section chief and director of the Proton Center. Since then, he's served as interim chair of radiation oncology at Emory and now serves as vice chair of radiation oncology at the University of Pennsylvania. The big news out of NRG Oncology recently is that after 15 years, Dr. Bradley, who has been serving as the chair of the Lung Core Committee, is now stepping down from that role, and we wanted to look back on his tenure and his many accomplishments over that time.
I too have known Dr. Bradley as a mentor, role model, and friend for well over a decade through NRG Oncology, and I personally owe him a huge debt of gratitude for the many opportunities I've had in my early career. First off, Dr. Bradley, I just want to ask you, what exactly is a disease site core committee, like the Lung Core Committee, for example, and how does it fit into the larger NRG Oncology structure? And what do you consider your biggest accomplishments over the past 15 years as a Lung Core Committee chair?
Well, good afternoon to both of you. It sure is good to talk to two people that I know very well, and I'm very appreciative of the podcast you guys are producing for NRG Oncology and other meetings. They're very entertaining to listen to, and I appreciate being invited to participate today. Stephen, to get to your question about what is a core committee, within Quadra Group, specifically within NRG Oncology, there are a number of committees that are housed within the big group. The core committees are disease site committees because protocols arise through disease site committees. In this case, lung cancer committee, or you could think about breast committee, GI, GU, etc. So those are disease site committees, and they have a core committee that's sort of the internal committee made up of a smaller group of members that help formulate and approve and review what clinical trials are launched from that cooperative group and submitted to the NCI for review. There's also a general committee, which is a larger committee that are also equally important, but a broader membership. Cores are the smaller group. You know, I'm really proud of what's happened over the past 15 years within the Lung Cancer Committee. The thing I would be most proud of would be all the mentees that have launched clinical trials, and many of them have completed and reported their clinical trials. But I think the most fun for me has been helping these junior investigators become senior investigators and reporting their trials and then seeing their careers blossom around that. I think that's the most rewarding thing that I've been able to enjoy, let's say.
Maybe if you could just share some specific examples of trials and mentees that you're particularly proud of.
As Lauren mentioned, I started this job in 2010, and so that was RTOG timeframe. So anything in the RTOG nomenclature that starts out with a 1-0 would be launched in 2010. So I go in chronological order because I don't want to play favorites here. But let's say Spring Kong did 1106, and that's recently been published. And Spring was a resident at WashU and then became an attending at Michigan, and then later at Case Western, where Lauren is now and is now in Hong Kong. But going back, let's go back 15 years ago now, we launched 1106 and have since reported it. You know, she's made many a contribution to the lung cancer literature. Another one might be NRG LU002, Puneeth Iyengar. He was a junior investigator at UT Southwestern. He now heads, I believe, what would be called a metastatic service at Memorial Sloan Kettering. His trial, LU002, looked at oligometastatic non-small cell lung cancer, 3 or fewer metastases, treated with systemic therapy plus or minus local RT. There are other examples: Stephen Lin, Kristen Higgins, Andreas Remner, Quinn Gwynn, Chuck Simone, and hopefully yourself, Stephen. We'll keep trying to get a trial launched for you as well.
So both Stephen and I know that what you describe, all of this mentorship and trial development, is a huge amount of work. There's been a lot of discussion nationally, lately especially, about the value of federal programs like the National Cancer Institute and NRG Oncology. and being good stewards of taxpayer dollars. We've talked before on this podcast about NRG oncology being really a huge bargain for the American taxpayer. But just how much time and effort have you put into developing NRG lung cancer trials over the years? And how much of the work of the Lung Core Committee is done at no cost to the American taxpayer?
Wow, Lauren, that is a good question, because I don't really know. I don't even think with leaders within the cooperative systems, and I'm talking about group chairs, I don't even think they know what the impact will be or is going to be on that clinical trials process. As far as I know, and as far as we are told, keep coming up with good trial ideas, submit them for review to the NCI, and we are still, I'm involved in those review committees still, and we are approving clinical trials. I haven't seen a change in that behavior yet. I worry that it may eventually come where that strain gets a little tighter and that fewer trials get through. As far as how much time goes into it, it's a lot of time, Lauren. You're talking about from concept. You generally, have to develop that concept. That means including co-investigators, a statistician. You need to get industry support typically. So you shop it around to different pharmaceutical companies to see if they are interested in the topic. And A would supply drug, or B would supply extra funding. You have to work within the other cooperative group chairs to help prioritize it within the steering committee group itself. And then you have to get it approved through the committee. So there's a lot of steps involved. It's a lot of work on a PI, a statistician, and a committee chair to get a concept from its original stage where it's just an idea all the way through to getting a trial opened. I certainly hope that we don't have a reduction in the amount of trials we're able to pursue through that mechanism. Clinical trials don't pay a lot. If you're at an institution and you open a clinical trial within any of the cooperative groups, you get paid the same, more or less, per trial, unless there's an extra industry funding for some reason or another. And it usually doesn't pay for itself. You usually need to open industry trials in addition to cooperative group trials to be able to run your clinical trials office. So I do think it's an inexpensive effort for what you get out of it. And hopefully they don't reduce the number of trials we're able to open and complete.
So again, I want to reiterate what Dr. Bradley's been talking about to our listeners, that while the American taxpayer pays for the overall administrative structure of NRG oncology needed to develop and perform clinical trials, by and large, most of the work that we do is largely voluntary, and it's only done for the purpose of wanting to cure things like lung cancer a little better. Dr. Bradley, pivoting a little bit, for many of us who are relatively early in our career, like Lauren and myself, you have been the only Lung Core Committee chair we've ever known. What was behind the decision to step down, and what's next for you?
Stephen, it sounds like you're telling me I should have stepped down a long time ago. No, I know you're just asking me why I stepped down now after a long tenure. I think, the way the rules are currently written, the cooperative groups collapsed from 10 to 4 in 2014. And so what was RTOG, GOG, and then SABP collapsed to something called NRG Oncology. And at that time in 2014, the rules stated that you would be approved for potentially 2 6-year terms, up to 12 years. So I was chair from 2010 to 2025. That's 15 years. I thought they would ask me to step down around 2022, but then they rewrote the rules so that in 2014 I have 12 years, which is like 2026, right? And so I just felt like now is the right time, that I have a lot of work to do at my current job. I stay busy that way. I think it's nice to get new blood in. Kristen Higgins has been named as the new Lung Cancer Committee chair. I'm thrilled for Kristen. If you know me and you know her, I've mentored her for 15 years, maybe. I don't know how long she's been on faculty at Emory and now at City of Hope, but I've had her run committee meetings. I've had her be a PI. I've worked with her at Emory for a 3-year period. So this is something I'm very proud of. I think the committee's in great shape going forward. I don't think there's going to be many gaps or any gaps to say in progress and what we're doing within the lung cancer.
That's such a cool legacy to get to, transition it to somebody that you have helped to mentor and develop over the years and have that relationship with and see them launch into this position now too. Imagine that that's got to be a special kind of rewarding.
Can I make a statement, Lauren? It
Yeah.
is so rewarding. That's kind of what I was talking about with mentorship. But I have to claim, I was not the one that made the decision to name the next chair. I was asked my opinion. We had some great people apply. Leadership chose that, but I'm certainly happy with their choice. And it's somebody that I've certainly mentored for quite a long time.
That's amazing. So the past 15 years, while you've been the chair of the Lung Core Committee, have definitely seen some seismic shifts in the lung cancer landscape. It wasn't too long ago that when a patient had lung cancer that couldn't be removed surgically, people would debate whether to even treat them, and these patients would often be written off to hospice or palliative care. Can you talk about the lung cancer trials that have been successfully completed under your watch? I know that you mentioned some of them, but I'd like your take on how things have shifted over time.
I'm going to take it back to trials where I was principal investigator, because preceding my chairmanship, I had been fortunate to be principal investigator for a series of trials that looked at radiation dose and volume with and without concurrent chemotherapy in locally advanced non-small cell lung cancer. Those were RTOG 9311, that was radiation alone, phase 2 dose escalation study. RTOG 0117, which we added concurrent chemotherapy and determined 74 gray was the maximum tolerated dose. RTOG 0515 was a single arm trial where PET was just now starting to be used in planning lung cancer volumes. So that was 2005. We had been using it at WashU as a simulator, PET CT simulation to plan volumes, and we did that through 0515. We had one elective nodal failure in like 52 patients. So after that, we stopped treating elective nodes in locally advanced non-small cell and just focused on what was PET avid. And then that all led to the phase 3 trial, RTOG 0617, 60 versus 74 gray with or without cetuximab. And I would argue on the radiation side anyway, that continues to define the standard of care, which is 60 gray and 2 gray fractions. And the radiation volumes are still the same, even though that was 20 years ago. Not to say we can't change. We can certainly change. We've tried to change. RTOG 1106 tried to use a PET adapted boost to increase radiation dose. Didn't work so well. LU001 tried to add metformin. That was not very helpful. We've done LU004, which dropped the chemo, and PD-L1 high tumors, just you give radiation and immunotherapy. And that was a phase 1 study. We haven't launched anything subsequent to that as a phase 2. We've looked at in small cell LU005, chemoradiation, adding immunotherapy, in this case, atezolizumab. Now we're looking at SBRT to the primary and chemoradiation to the nodes as the experimental arm in the trial called NRG LU008. Again, around this theme of trying to increase the radiation dose in other ways or add immunotherapy in other ways. So that's been the theme. At the same time, the cooperative group, RTOG, now NRG Oncology, also ran a series of trials for early stage disease with stereotactic radiation therapy. And you all remember those. You've read them: 0236, 0813, 0915, 0618. I was not the committee chair, but I certainly contributed heavily to the accrual to those trials. And that led to the trial called Pacific 4, or RTOG 3515, which added an immunotherapy drug after completion of SBRT. That drug was durvalumab. Those events are still accruing, so we're still waiting to hear the results of that study. So you might argue, looking back over time, that the way radiation is treated that the group has helped define the way radiation's treated both early stage and locally advanced non-small cell.
There's something else I'd also like to touch on that I believe you've been directly responsible for with the Lung Core Committee. Before you became chair, and even in the early days of your chairmanship of the Lung Core Committee, when I first joined, the committee was actually composed of fairly senior people like Jim Cox, Wally Curran, Bill Sauce, Bob Timmerman, Ritsa Kukamaki, to name a few. This was a committee dominated mostly by fairly senior and established, by and large, men, with very few exceptions, very few women. Today, the committee I've noticed is much younger, has more women, representation from many more NRG institutions, early career investigators, some of whom you've mentioned: Andreas Ribner, Kristen Higgins, Steve Lynn, Heath Skinner, Puneeth Iyengar, got major career breaks under your mentorship. How intentional has this been, the reshaping of the committee, and what has been your vision in shaping the core committee, and how might perhaps other core committees learn from your strategy?
Stephen, thank you for noticing that. That was very important to me. I felt like that we should be a vibrant committee, that it should be made up of elderly people like me now. I wasn't so elderly before, but I'd say I'm amongst the older committee members now. But we should have a healthy flock of junior investigators with new ideas to come to the committee. And I encourage new ideas to come from junior investigators. And if they had an idea and the core committee liked it, we pursued it. We tried to spread the wealth around to different institutions, to different people. And if you notice, it's not one person doing all the work. We spread the work out amongst many, many, many principal investigators and tried to give everybody an opportunity to have a trial and to open a trial. Because I think in the cooperative mechanism, the more people you have, the more institutions you have accruing, the more success you have, because more people can accrue to the trial. The more institutions you have accruing, the faster the accrual. So that gives great opportunities to them. So it's sort of a bigger, more people, the better type of philosophy. I never even excluded people from coming to meetings. I always encourage people to come. And some of them really got involved and took ownership. And that's great. I want that to continue. I think it will continue. I think within NRG itself, and I know, talking to the other cooperative group leads, which we talk often, there's a real focus on getting junior people involved, reviewing committee applications, and rotating people off and rotating people on every year. 3 to 4 people, new people, come on the Lung Cancer Committee every year by intention. They've applied for it, and as a result, we rotate 3 or 4 off. So there is a constant flow, and that is intentional.
I think it's just really forward thinking to be mindful of growing, the fleet of people that will carry the field forward as, you advance in your career, and time gets the best of all of us, but we don't want time to get the best of our efforts to move the needle for our patients. So we've talked already about some of the biggest accomplishments of the Lung Core Committee under your leadership, but there's also a saying something like that you can't truly live without having any regrets. I wanted to touch on something that I'm sure caused some disappointment, at least in moments, to you with NRG Oncology. With NRG Oncology, you're very well known as the principal investigator of NRG Oncology, or RTOG 0617, which was a trial of concurrent chemoradiation for locally advanced non-small cell lung cancer that asked 2 questions. First, it asked the question of whether it was helpful to use higher doses of radiation to 74 gray versus the historic standard dose of 60 gray. Second, it asked the question of whether adding cetuximab to target the epidermal growth factor receptor would improve outcomes for these patients. And ultimately, neither higher dose radiation nor cetuximab worked to the benefit of patients in this setting. But to everyone's surprise, more high doses of radiation ended up actually being detrimental, with more people dying in the 74 gray, or the dose escalated group. I know that as a community, we've learned just so much from that trial, but how disappointing was 0617 to you, at least at times, and how did that shape your outlook and approach to the Lung Core Committee afterward?
Well, thank you for that question, Lauren. I get asked not about how disappointing it was, but I get asked about the results quite often. I'm going to, state a fact that not everybody knows, but 3 out of every 4 randomized trials, the control arm wins. I know that's hard to believe because you go into a trial, and if it's a phase 3 trial, you really think the experimental arm is better, or you would not be pursuing that study. Yet 3/4 of the time, the control arm wins. You go back over time, you look at trials, and that's true. So that happened in this study. We had done lead-in studies that I just walked through, and the phase 2 results were outstanding. The best, L0117 was what it's called, RTOG 0117. And we were really excited about the experimental arm in RTOG 0617. And we launched a trial and it accrued. And at an interim analysis, I was watching my son play soccer at a soccer game, and I wasn't even thinking about the DMSC calling me that day. I didn't think there was any chance of it. And I got a call from them and said, you've crossed a futility boundary and we're going to close the trial. And I was shocked. I was like, oh my God, I can't believe it. Could the results be wrong? Could the curves have been reversed? And we dug into it. And you know what? When you have a negative study, people dig into, and the investigators, including me, dig into why was it negative? And often you'll learn a lot from a negative study. And I'd say we learned a lot from that study, like heart dose, all this stuff today about heart dose, all triggered by 0617. Stephen's done work on IMRT showing less toxicity than 3D, because about half the patients in 0617 were treated with IMRT and half with 3D. And we use that today to argue with insurance companies to use IMRT for locally advanced lung cancer. I don't use 3D anymore. And if I get called by an insurance company or need an appeal letter, I cite that secondary analysis. There's all kinds of things we've learned from that. And so it's disappointing. Yes, I certainly thought the higher dose would win, but I'm not necessarily disappointed with all the things we've learned that came after that we apply today. So I guess I'm finding a golden thread within the negative story. Was it disappointing? Absolutely, because I thought it was going to win, but I'm not disappointed with all the things we've learned as a result.
So you just mentioned your son's soccer game, and I think that's a nice segue into what I wanted to ask about next. I feel very lucky to have been able to hang out with you over the years and see a side of you that perhaps not everyone might know. We had just hung out last summer in Singapore at the Particle Therapy Cooperative Group and had a good time just talking about any number of things. And I've appreciated your advice over the years, not only on radiation or medicine or leadership, but also finding the right work life balance. You told me things like people should be able to attend their kids' T ball games and not miss out on important things in life. I remember when my first son was born and I had to miss the NRG Oncology Lung Core meeting, and you told me, "Don't worry about it. You're exactly where you should be with your newborn son and wife." And I wanted you to talk about your philosophy on work-life balance, especially because of the amount of time and energy we all put into NRG Oncology, largely as non-compensated volunteers. And what things have worked and haven't worked for you and your family during your career?
Well, that's a tough question. I appreciate you bringing that up. I wonder sometimes whether you should be on email or answering things all the time. There's certainly no shortage of work. Could keep you, all waking hours. You could be responding to work, usually our daily life work, like taking care of patients, but on the academic side, publications or running trials. I guess I tried to set limits so that when I knew family stuff was ongoing, that I was not going to miss that. I'm the kind of manager, I don't micromanage. I try to empower people that work with me, or if you're working on a protocol or something, you're empowered to run a call or make a decision so that, it's not all falling to me and I could be updated. There's pros and cons to that, but I think that's a good strategy in life. And I think that's a good strategy, working in departments at work. You establish groups that tackle problems and you let them tackle those problems and you don't have to micromanage that. Yeah, work-life balance is really, really, really important. And we have it pretty good in radiation oncology. You have to get back to people. The other thing I like to do is like I set a timeline. I try to respond to email like within 48 hours. So I may not respond that day, but I try to respond fairly quickly so that you have an answer, you're paying attention. I'm not always able to do that, but I think it's good to set timelines for things and expectations. Like if you're trying to open a trial, you set your expectations for your team. Let's have this together in 2 weeks, et cetera, something like that. So anyway, thanks for the question. I'm not sure I'm the best at that, Stephen, but I do try to pay attention to that.
I've got to say, you're definitely one of the more responsive leaders to emails who I've ever worked with.
And clearly managing to balance it, at least with soccer games. So I think you're doing at least okay, probably better than okay. As we move to a new era for the NRG Oncology Lung Core Committee, what do you see as the biggest challenges and opportunities now in lung cancer? There's so many new things out there, like new imaging techniques, adaptive radiation, antibody drug conjugates, and just so many others. What kind of hope can you give to patients out there facing a lung cancer diagnosis, and what do you see as next?
Well, we've got lots of ideas, Lauren, about the next wave of studies, what they should be. That sort of teed some of them up. I say some. Some are teed up to take off. Hopefully will take off. One is reirradiation, as you know, with immunotherapy. We even published a paper recently from Penn, how the prognosis of patients who fail first line chemoradiation and have a local recurrence with immunotherapy, the survival for those patients is increasing. So can we launch a trial in the reirradiation setting of patients with immunotherapy, be able to give a lower dose and impact prognosis? So we've got that idea percolating through NRG Oncology, and hopefully we'll submit it to this NCI steering committee and see what they say. People are adding second immunotherapy drugs, so drug A and B plus radiation. There are ideas out there about maybe we don't need as much radiation at all. Maybe if for a locally advanced lung cancer, you can just irradiate the primary, not the nodes, in the setting of immunotherapy and get a response, let's say preoperatively. Maybe you don't need to irradiate everything. You just prompt an immune response using radiation as a tool to stimulate the immune system. I think there's a lot of excitement, a lot of ideas where we could pursue in lung cancer in this new era of immunotherapy. Another branch, I don't know, you guys know that I'm interested in flash radiation therapy overall. Our conduit to flash is proton beam. We're launching a proton beam reirradiation flash trial for head and neck here at Penn later this year. I would love to use flash for non-small cell lung cancer, recurrent non-small cell lung cancer, or ultracentral lung cancer. So hopefully there are things that we can do to continue to evolve. And I would say hopefully we certainly can do things to continue to evolve as a specialty. Immunotherapy, some medical oncologists say it cures people. I'm not so sure. I know radiation does. So we can't just sit on our hands. We've got to play an active part in getting these trials and pursue it.
Dr. Bradley, I'd like to thank you again for joining us on the NRG Oncology podcast. For all of you listening in today, we had Dr. Jeffrey Bradley, the outgoing chair of the NRG Oncology Lung Core Committee, looking back on the past 15 years as he transitions out of this role with many pearls of wisdom that he's learned along the way. Again, Dr. Bradley, thanks for joining us today, and our best wishes on the next chapter of your career.
Thank you, Stephen. I am going to be heavily involved going forward in accruals and anything you all need me to do within the cooperative group. I look forward to that phase of things.
The NRG Oncology podcast is supported by grant funding from the National Cancer Institute, and content of this podcast does not necessarily reflect the official views of the National Institutes of Health. Thanks everyone for joining in, and happy clinical trials.